third annual Leon Shift lecture. And we're very fortunate today to have Dr. Norah Terrault as our speaker. Dr. Terrault is Professor of Medicine and Director of the Viral Hepatitis Center at the University of California, San Francisco. She's really a world-renowned expert in viral hepatitis, especially in the setting of liver transplantation. She has authored more than 200 original articles, review papers, and book chapters on viral hepatitis, and also has served on the editorial board of multiple professional societies, guideline writing committees, and served as deputy editor for the prestigious journal Liver Transplantation. She's an NIH-funded researcher and is an investigator in ongoing trials of antiviral therapy in chronic hepatitis B and hepatitis C. So please join me in welcoming Dr. Norah Terrault.
Thank you. Well, thank you very much for that lovely, lovely introduction. And I want to just take a moment to thank Dr. Schiff for inviting me. I'm just going to say, I know he's beloved to all of you, but he's beloved to many outside of this room as well. And I'm just going to say, it has always been such a pleasure to just have you as a colleague and as a mentor. Thank you very much. Now, everyone in the room knows that the arena for HCV treatment has been really revolutionized in the last several years. And I saw patients in the clinic yesterday and newly diagnosed patients, whenever they come in and are very afraid of their new diagnosis, I always they leave the clinic with my telling them, don't worry, we're going to cure you. And that really is a statement that you can broadly say across the board, I think, for the vast majority of patients. So what I focused on today for the talk is on the patient with cirrhosis, because I think they present still some unique challenges, even in this era of really quite amazing direct antiviral therapy. And so what I thought I'd outline is really, I'm going to weave my way through several different aspects related to treating patients with cirrhosis. First, I'll speak a little bit about the initiative to really eliminate HCV in the United States and how getting to that cirrhotic population is going to be important in that regard. Then we're going to talk a little bit about available DAA therapies and where the gaps exist, especially as it relates to patients who have cirrhosis and decompensation. And then I'm going to sort of focus a little bit more on two kind of opposite ends of the spectrum. The one is the patient on the waiting list for transplant and the challenges we have in terms of deciding whether to treat or not. And then on the flip side, the patient who's made it through treatment, has SVR, and then how we're managing them after their SVR. So first, just to make the point that treatment is effective at achieving the hard endpoints. When we do clinical trials, we look at a sustained virological response as being the equivalent to a virological cure. But what really matters is, can we translate that virological cure into something meaningful from the point of view of mortality or liver-related complications? So these are data that are a few years old and actually represent the interferon era of treatment. But this is an important study because it's one of the few studies that actually uses a control population that's the general population. And the point being, as shown on the left, that even if you have advanced fibrosis, somebody who has bridging fibrosis, cirrhosis at the time they're treated, if that individual achieves cure, over the next decade, their all-cause mortality, if they've achieved cure, approaches that of somebody who's never had hepatitis C. So that's a really remarkable ability to really transform the natural history. On the other hand, if you have somebody who's treated and you don't achieve SVR, then you can see that they remain at risk for the complications of cirrhosis, decompensation, liver cancer, and liver-related death. And you've seen this, I'm sure, many, many times before. If we're going to get individuals to achieve an SVR, there's a whole cascade of care that has to occur before we can get them to that cure. And here in the United States, where there's really a big push now in terms of trying to achieve HCV elimination by 2030. There's a lot of attention paid to this cascade of care. Everything from identifying the individual who's infected through linking them to care, getting the appropriate testing and staging done, and then ultimately offering treatment. And the patients that have cirrhosis are in that cascade of care as well. Individuals who have cirrhosis that have not yet manifested a complication are largely asymptomatic. And so they're out there, blissfully unaware that they're infected and have an advanced stage of disease. And we know that the vast majority of individuals in the United States who are at risk for having cirrhosis are the baby boomers. And so this is data I'm sure you've also seen as well. This is data from the NHANES study. And what it does is it maps out the prevalence of hepatitis C by year of birth. And what you can see highlighted in the pink is that the individuals who were born between 1945 and 1965 represent 75% of the cases of individuals with hepatitis C. Now, this epidemiology is actually shifting a bit now that we've got this kind of epidemic of heroin use in the United States. We now have a younger generation of HCV-infected individuals that are now joining the population of those with infection. But in terms of those that have chronic disease and have had it for several decades and are at risk for cirrhosis, it's really the baby boomers. And that's why there's this big push in terms of doing screening of baby boomers so that we can identify these individuals. And shown here is why it's important that we undertake the finding of these baby boomers with some urgency. So when I give talks, I tell individuals it isn't good enough to find the baby boomers in 10 years. We need to find them in the next few years. Because as shown in this diagram, which maps out sort of the natural history of those baby boomers, you can see that by the year 2020, that about 40% of the baby boomers will have cirrhosis. So clearly we want to get to them and treat them before they get to cirrhosis, or at least if they're cirrhosis, we want to get to them before they present with liver cancer and decompensation. So the urgency to find the baby boomers and offer treatment is really very, very important at this time, and really is the reason there's all these strategies to try to intervene in terms of identifying them through screening programs. We've known since about 2010 that Hep C now is sort of a very important cause of mortality in the United States. This is where we kind of crossed the line and became more important in terms of lives lost than HIV. And that number has continued to go up. We're hopeful that now with the advent of DAA, that when we look at data in 2016-17, that we'll start to see that this will start to decline. And I'm going to show you some data later that suggests that maybe we're already seeing some of the benefits of DAA therapy. But this real mortality risk related to HCV infection remains. And the other thing that's become very clear from additional studies is it's not just liver-related mortality that we're trying to prevent when we treat individuals with hepatitis C. We're also treating them for non-liver-related causes or morbidity. We now know, for example, that Hep C is a cause for diabetes. It's linked with higher rates of lymphoma. There's higher rates of end-stage renal disease. So when we treat a patient with hepatitis C and achieve cure, we're not only going to prevent them from developing those liver-related complications, but hopefully also prevent them from developing the non-liver-related causes of mortality. So mortality in this population remains high. Remember that the baby boomers right now are sort of in their late 50s, and they're at risk for these other diseases as well. And so offering treatment, identifying them is key. So I've sort of made this point that the baby boomers are really the primary target if you're focused on trying to find individuals with cirrhosis. Certainly, we should do broader screening for individuals who are at risk for the newer infections through injection drug use. But for the baby boomers, this is where we need to go if we want to try to prevent cirrhosis-related complications. The median age of the baby boomer cohort right now is 62, with a range from 52 to 72. So they're aging. So the other thing about the baby boomers is that they have this competing risk of dying of other things. And we've sort of known that they do have an early mortality, but they also, because they're aging, are going to die of other things that happen when you hit 65 and 70. And so they're going to have more advanced fibrosis, and they're going to be more at risk of having other comorbidities. Those comorbidities, in fact, may make it more difficult for us to achieve cure in some of those patients. And if we look 5 years from now or 10 years from now, when we're supposed to be close to eradication or aiming towards eradication for Hep C, then we're going to be dealing with really quite an older cohort, and they're certainly age out. They're going to age out because they're going to die of their liver disease or they're going to die of comorbidities. But in the next decade, those baby boomers remain the biggest group in terms of costing us in terms of healthcare dollars. They're the ones that are going to be coming forward and costing us money in terms of managing their cirrhosis, their liver cancers, and their liver-related end of life. So again, some urgency there. And there's a very nice paper was published last year that sort of tried to map out what we can anticipate with current DAA therapy in terms of the impact that we could have in terms of reducing the numbers infected, and as a consequence, all the numbers that are going to be at risk for those complications. In this analysis, which sort of maps out treatment over time, they assumed that we would treat 280,000 patients per year. And that was based on projections from 2015. That's kind of where we were headed. And it's probably a reasonable number that that's where we're going to be in terms of offering treatment per year. And what this shows is that really in the next several years, if we're able to maintain that level of treatment, we'll very rapidly bring down this generation of individuals who are at risk. And what you'll see is the group that's in gray represents the group that has a sustained virological response. That's a much bigger group in 5 to 10 years' time. But the orange and the blue at the bottom represent the group that's going to be the hardest for us to get to. And that's the group that doesn't yet know they're infected or is out of care. And so we're going to continue to have that group. That the number is estimated to be about 900,000 in 5 years' time, and maybe as little as 700 plus thousand in 10 years' time. But they're going to be there. So again, the message meaning that we need to be thoughtful about trying to find individuals, because really, unless you screen, you're not going to know the patient's infected. So our number one challenge, I think, with respect to cirrhosis and trying to prevent the morbidity, mortality rate of cirrhosis is because we still have many people untreated and many of them unaware. So that's the major gap. It's estimated that 50% of individuals who have hepatitis C today don't know they have it. So a lot of emphasis on the part of primary care, internal medicine, and specialists to be able to do screening to find those individuals. So that's the first challenge. The second is really to think about what the therapies are and where the gaps may exist for the patient who has cirrhosis. So in 2017, we have got sort of many tools in the toolbox. For individuals with genotype 1, which is the most common infection in the United States, we have 6 different treatments that we could potentially choose from. And at the moment, the decision about what you use for a given patient is really dependent on their genotype, to some extent their prior treatment experience. Renal status matters because some of the drugs can't be used in the setting of renal dysfunction. Cirrhosis, also, especially if they have decompensated cirrhosis, and then at least in the California environment, I'm sure it's the same here, it's the insurer preference that drives a lot of decision making. The good news is that all of these 6 therapies, for the most part, offer the same opportunity for a high degree of cure. And that's shown here that, as you all know, we're now at the point in 2017 where really, when I talk to patients, I tell them their chance of success is 95%, give or take. We now have regimens that are pangenotypic, meaning a single drug that can be used across all genotypes and gives that kind of efficacy across the board. So we're really in an amazing place to be able to talk to patients about therapy. Now, for patients that have hepatitis C and cirrhosis, there's some nuances with respect to our decision making, because we realize that as the severity of their liver disease increases, some of our treatment options decrease. So here are 2 patients that really at first blush look like sort of they're very similar and that you should be able to treat them in the same way. They both are cirrhotic. They both have had endoscopies that show varices. One of them has encephalopathy but no ascites, and you can see the lab parameters shown below. And none of them have clinically decompensated disease except for some mild, in the case of patient number 1, hepatic encephalopathy controlled by lactulose. But my point in showing these 2 cases is really the way we think about how we're going to treat these patients is we have to calculate their Child-Pugh score, because the drugs that were developed for hepatitis C were really tested by Child-Pugh class. So when we talk about cirrhotics and treating patients with cirrhosis with compensated disease, it's really a Child-Pugh A patient. But if they slip into Child-Pugh B, then we really are more limited in our drug options. So for example, the patient on the right is somebody who actually is Child-Pugh score B. So this patient has very different treatment options than the patient number 1. So shown here in a tabular form is all of the therapies that I had in the diagram before. And to make the point that if you have Child-Pugh A cirrhosis, you can use any of the options that are in this table, so wide open. But if you move to having Child-Pugh B or C disease, as you can see here, basically about half of the drug therapies that we have then drop out of the algorithm of use, and primarily because we can't use protease inhibitors in individuals who have decompensated cirrhosis or Child-Pugh B cirrhosis. So what that means is that we have fewer drug choices for our patients who present with Child-Pugh B cirrhosis, even though they may be clinically compensated. So because of this issue of the protease inhibitors being contraindicated because of concerns regarding hepatotoxicity, we do have a few less drugs to work with. Now, most of the part, we can offer therapy to most patients, but there's a few patients actually that we can't treat right now. And those would be patients that happen to have decompensated cirrhosis, Child-Pugh B, and have renal dysfunction. Because as it turns out, all of the drugs that are eligible to be used in patients who have Child-Pugh B or C cirrhosis require the use of sofosbuvir. And sofosbuvir per label is not to be used in individuals with creatinine clearances under 30. So if you happen to have a patient with decompensated cirrhosis with renal dysfunction, today we actually have no approved therapy for that patient. So there are some limitations with treating patients, but primarily it falls under the umbrella of patients who have decompensated cirrhosis. I would also say that you could say, well, okay, well, maybe the success rate isn't going to be 90 or 95%, but even if it's reasonable, we should proceed. And I think that that's probably the way that most of us have approached this. So these are now showing you the SVR rates or the cure rates by Child-Pugh class. And you can see that as you move from Child-Pugh A to Child-Pugh C, that you see this modest decrement in the SVR rates. So you move from sort of 90 to 95% down to about 80% for somebody who's got Child-Pugh C cirrhosis. Also shown on this slide is that your SVR rate or your cure rates go down for two reasons. One is you are getting more relapses, so the treatment is not as successful. But the other thing that's happening, obviously, as you move through the Child-Pugh class is the patient's at greater risk of dying during treatment because they have advanced liver disease, and that's also highlighted by these bars. And just to give you a sense that if you step outside clinical trials and go into clinical practice, this is the big VA national database in which they looked at their treatment success in patients with and without cirrhosis. The cirrhosis group is shown in the light pink bars. And you can see that pretty much across the board, there's often a very modest decrement in the success rate in individuals who are treated, whether it's genotype 1, 2, 3, or 4. Most of the time, you're seeing slight decrease in the rates of success if an individual has cirrhosis. So it's not to say we don't treat patients with cirrhosis. An 80% success is still outstanding compared to what we had before, but just to recognize that you're going to be having potentially to deal with more treatment failures in this group of patients. And in terms of what is influencing, like why do they get lower response rate? They're adherent, so why are they getting lower SVR rates? And I'm not sure I have the answer, but I think there's some hints in the data that are available. So if you look at this study, which uses sofosbuvir, declatosphere plus ribavirin, they're treating decompensated cirrhotics. You can see that as you have sort of worsening portal hypertension, as evidenced by the presence of ascites or hepatic encephalopathy, that you see that decrement in SVR rates. And clearly, as your liver synthetic function declines, you're seeing marked changes, particularly with the albumin being an important marker. So while I don't know what the causes are for the higher virological failure rate in patients with advanced cirrhosis, potential reasons is that you're just not able to deliver the drug to hepatocytes, that we know there's, the endothelium, it becomes sort of fibrotic, and distribution of drug to the hepatocytes may be enhanced. We also know that as individuals develop portal hypertension, they have more shunting, and so actually there may be less of the portal blood flow actually going to the liver. And for all of those reasons, we may actually be seeing less drug in the hepatocyte to deal with the viral load that's within the hepatocytes. We don't know for sure, but we clearly see that there's this decrement. So you might ask yourself, well, the good news is there's always a pipeline and we have new drugs coming. And indeed, in 2017, we're expecting 2 new combos to become approved. The Valoxavir, Sofosbuvir, Valpatisvir, so that's at the top there, that's expected to be approved middle of this year. And the Gliclapivir and Beprentisvir is also expected to be approved this year. Now you would say these drugs, what they're offering is kind of greater potency. They're especially good against individuals who have already failed a prior DAA regimen. And you might ask yourself, well, maybe these triple combos will be good for our patients who have cirrhosis. But the unfortunate thing is that all of these new combos can create a protease inhibitor. And they're not even evaluating the drugs in patients who have Child-Pugh B or C cirrhosis. So unfortunately, while these new drugs are coming, they're not going to help our patients who currently we have with mildly decompensated or severely decompensated disease. So for that group of patients, they're going to remain a group that doesn't have good treatment options. So this is still one group when we, talk about unmet need. I would say the decompensated patients, and especially decompensated patients who have renal failure, are a group that is of high unmet need. And so we do need to try to strive to have more of those patients achieve cure, because remember, cure is what's linked with the decrease in mortality. If we don't get cure, we're not really helping them any. The other thing I didn't highlight by the treatment, but every study that's done in patients with decompensated cirrhosis, we always have to add ribavirin to the mix. So even though we have these great DAAs, they always benefit from actually having ribavirin added. And ribavirin brings with it a toxicity that does make it more difficult to use in our patients with advanced fibrosis. So again, we have room to improve here. This is challenge number 2, is to find better therapies for cirrhotics and especially those with decompensated cirrhosis. So now I'm going to shift to talking about, again, more in detail, the patient with decompensated cirrhosis. So I've already highlighted that they certainly, when treated, have a good chance of response, 80% perhaps, but perhaps a greater risk that they'll fail. But we've treated a lot of patients with decompensated cirrhosis. This was a group that in the short term has the greatest likelihood of dying of their liver disease. And what's I'd like to share with you is really data we have that shows what it can achieve. It's really quite striking how quickly we can see improvements in patients with decompensated cirrhosis who are treated and achieve an SVR. We've seen, and I'm going to show you, reversal in symptoms of decompensation, improvements in their MELD or Child-Pugh score or class, improved quality of life, and we also have data of avoidance of liver-related death and avoidance of need for transplant. So this is really something that was never achievable before with therapy. When we had interferon therapy, we couldn't use it in this population. So when somebody presented with decompensated cirrhosis, there was only one treatment for that patient, and that treatment was transplant. So now we have an opportunity to potentially rescue these individuals sort of from the precipice of transplantation, and I think there's a great interest on the part of the transplant community on how do we do this, and how many are likely to be able to achieve that ability to avoid transplant. So some very recent data that we looked at was the UNOS data, and it's just, UNOS is just looking at how many patients have been listed, okay, over time. And so what it's showing you in the panels is the individuals who are listed overall in A. Then on the list, we also can indicate if they're listed because they have decompensated cirrhosis or if they're listed because they have cancer as their primary indication for transplant. So the Hep C group is in red. And what we're looking at here is 3 different eras. In white is the era before we had any treatment really at all, no DAAs. The light gray is the time when we had protease inhibitors first became available. And we used to use them with interferon and ribavirin, and there was some brave sorts like myself and others who treated patients on the wait list trying to get them to get SVR so we could avoid transplant. And then you can see it's a shorter time period, but we've had now all oral DAA therapy for a few years now, and you can see sort of already in that relatively short period of time, the number of patients listed for needing a transplant for hepatitis C has already shown a very sharp decline. Now, you could argue, well, maybe it's those baby boomers that are just getting old and they're not candidates for transplant. And certainly we thought about that when we did this analysis. But the rate of decline is much sharper, as you can see. So if it was just due to sort of attrition because patients are dying of other things or you know, and not making it to be considered for transplant, then I think we would have seen a more sort of continuous decline. But it's very sharp, a very rapid drop-off, especially in the decompensated patients. And I think it reflects in the data I'm going to show you how quickly we can take patients who are decompensated and give them back some compensation. Interesting, I think, also in this study is shown in red is that even cancer, indications for cancer seem to be on the decline. And so whether we can also potentially reduce the need for transplantation for HCC is, I think, a very intriguing question. So just a little bit more about the wait list. So I think I've shown you that there's a clue among the wait list patients that maybe DAAs are making a difference. So now I'm looking at sort of the wait list data from UNOS over the last several years. And I use this primarily just to highlight that when we look at the wait list, it's a very, it's changing at all times. There's about 10,000 patients added to the wait list every year and 10,000 that fall off for different reasons. And obviously, half of them are falling off, or about 6,000 are falling off because they get transplanted. That's a good way to fall off the list or be off the list. But what I want to highlight here is that there's usually about 3,000 per year that fall off because they get too sick. So you get on the list, but you don't get to transplant. Everybody knows we have long waiting times in many areas, and patients really don't survive to transplant. And 30% of the patients on the wait list are patients with hepatitis C. So if you sort of take a third of that 3,000, that means 1,000 patients per year are really on the list, need a transplant, and don't get it. So can we rescue those people? Can we actually pull those people back so that we don't see them dying on the list? And then there's been a small, and I think what we're interested in also looking at over time is whether people improve to the point where they don't need to be transplanted. And that's shown by the green arrow, where you see that every year about 600 patients are taken off the list because they get better. And again, if we extrapolate that to the hepatitis C patients, maybe 200. What we're hopeful that we're going to see, if we look at data, this is the most up-to-date data we have from the full wait list, that we would be able to see that number of taken off the list because of improvement would go up for our hep C patients as well. So what are the data in terms of our ability to kind of reverse decompensation? So these are data from studies using Civosphere and Ladiposphere, and there were two very large studies done, one in US, Canada, and the other in Europe. And they took patients who had a Child-Pugh score greater than 7, and then treated them with the treatment, and then looked at them after SVR. And then 24 weeks after they completed the therapy, they evaluated their Child-Pugh score. And you can see that the vast majority of people get an improvement. So overwhelmingly, people are going to get better if you treat them. There's a small percentage, as you can see in red, that get worse, but majority of patients either improve or stay stable. I think the remarkable thing here, if you look at the Child-Pugh by class, so if you take a Child-Pugh C patient, which is really our most advanced patient with decompensation, and look at them 24 weeks after they finished treatment, 64% of them had been sort of downgraded from a C to a B, and 12% of them had gone from a Child C to an A, which means they've gone from being decompensated to compensated. So, and that's with just 24 weeks of treatment. So I think we're all pretty excited to see, well, what happens if you follow them longer? Well, here are some data that come from a slightly different source. This is looking at there's a ongoing kind of long-term study in patients from trials that were treated with soft-base DAA therapy. And you can see in the bar on the left, they've received an assortment of different types of therapy, all of them soft-based. And then what we're looking at is really longitudinal follow-up. So instead of just having 24 weeks of follow-up after they finish treatment, these studies are now out, beyond a year or more. And shown in the bars is sort of the improvement in the MEL score. Does it get under 15? And why do we pick 15? Well, in many transplant programs, 15 is used the cutoff for referral. So if you have a score over 15, generally you should be getting on the list for transplant. If you're under 15, maybe not. So they're using that as the cut point. So you can see that if you started out with a MEL score under 15, most of them stayed there, although there are a few that actually over time got worse. So it doesn't guarantee you're going to remain stable. So in the top set of bars there, you can see about 20% of patients over the ensuing months to years, really, a few of them actually still got worse. So I had a MEL score that went above 15. But probably more impressive is the group on the second set of bars at the bottom, which if you had a MEL score over 15 when you started, how many of them still had a MEL score over 15? And that is, you can see the majority of them drop under 15, right? So if you start out a little sicker, maybe you have more room to show improvement. I think that's partly what we're seeing. But it does suggest that about 80% of patients will improve, and they sort of sustain it. But it also shows, if you look at the green bars, and I'm going to use my little point here. I'm going to see if I can make this work. So if you, oh, hang on. Sorry, that won't work. So, okay. This percent here. So notice that it actually just doesn't budge. Now, it might not be the same patients. They might be moving around a little bit. But that suggests to me that there's 20% of patients who just won't get better. And so the agenda really for us that really manage patients on the wait list is, can we figure out who those 20% are? Because those individuals, really are not really going to be, it looks like, get better from treatment, right? So there's different ways of looking at the data, and this is just one more way of this kind of dilemma we have of patients that are on the wait list. So obviously when a patient's decompensated and we treat them, we hope they're going to be in that group of patients that gets an improvement in their MEL score, an improvement in their CPT score, and hopefully comes off the list because they're so much better. But we are all concerned that they might get a little bit better, but not better enough. And that's shown in this slide here. If you look at the red group is the group that's waiting still. They were waiting at the time of their pre-transplant, and now they're waiting sort of post-DAA, and you can see that number went up. So the idea is that some patients actually got better, but there's still a large group that are still waiting, meaning they got better but not better enough to get off the waiting list. And there's a term that's being used sort of in the lay press called MEL purgatory. And that refers to somebody whose MEL score, say before they had their DAA therapy, their MEL score was 20. And now they got treated and their MEL score dropped down to 14. Well, that's a nice improvement, but maybe they still have refractory ascites. Maybe they still have hepatic encephalopathy. So their quality of life is not better. They still really need a transplant. But now with a lower MEL score, they're actually farther away from it. And so, in fact, we may have done a sort of a disservice to the patient by actually pulling away access to transplant for them. So this has become a big challenge for us that manage patients on the waiting list, is to offer treatment or not, to treat or not to treat. So we're looking for data. How can we learn more about this to make a good decision? And this is nice data that came from Spain. It was a multi-center study where they treated patients that are on the wait list. And what they looked at here was the cumulative rate of being able to delist people for getting better. So that's very good data because we didn't have it up until this point. And it shows that if you follow people out, about a year after their treatment, about 20% of them will be able to come off the list because they're better. So that's a good number to hang your hat on. And then they looked at, well, what predicts if somebody's going to be able to come off the waiting list? And it turns out that the best predictor turns out to be what your MEL score is at baseline. And they found in their study that basically MEL scores under 16, they have about a 50-50 chance that they're going to be able to come off the waiting list if you treat them because they get better. But if your MEL score, for example, is over 20, then your chances of actually being delisted was only 15%. And in their paper, they concluded that perhaps those patients should not be treated. So kind of to put it in, this is the diagram I sort of think about every time I have a patient in front of me, is really, if I choose to treat a patient, my goal here is that I think I can get SVR and that I'm hopeful I'm going to be able to stabilize their liver disease and allow them not to have a transplant. Or maybe it's a patient with liver cancer and I want to keep their liver disease stable while they're being treated for their HCC. But I have a goal in mind. My goal is to do something that's going to allow them to survive, to either get treatment for their HCC or to come off the list entirely. But the downside of my undertaking treatment in that patient is that I might cure them, I might stabilize them, but I might put them into MEL purgatory. And so you have to have that conversation with the patient because they have to know that that's one of the possibilities. And the other thing that's kind of come up more recently is that there are a lot of Hep C positive donors. And in general, most programs only put those into patients who have hepatitis C. And so there's a lot of discussion about, we shouldn't trade our patients on the waiting list so that they get early access to these other donors, because of course getting transplanted is the goal. So it's hard. It's a hard decision, and I think I struggle with this probably more than anything in my clinical practice. So the concept is, can we define the point of no return? Can we define a point where the patient doesn't gain anything from being treated? We get an SVR, but we don't really result in a mortality or a morbidity benefit. And the clues we're getting from the data, I didn't show you everything, is that older age is a negative factor. So if you're older, less likely to get the benefits. If you have more advanced portal hypertensive complications, so if you have refractory ascites or you have pretty bad encephalopathy, probably not going to get a lot of gain clinically by being cured of your SVR. And then, as I mentioned, high MELD or CPT scores. Clearly, we need more data. That's sort of the other kind of caveat here about this whole topic. And we are getting it slowly but surely. But in the meantime, I think every patient who's on the wait list is kind of having difficulty. At UCSF, this is kind of the algorithm that we've approached. So we sort of lump our patients into three broad categories, largely based on Charles-Pugh score, but really with a few other caveats thrown in, recognizing that the risk of death while they're on the waiting list goes up. So the other thing I sort of struggle with when I make a decision not to treat a patient who's on the waiting list is that maybe they're going to die of their liver disease before they get to transplant, and could I have maybe saved them? So that's the sort of dilemma you have. So their risk for liver-related complications goes up the sicker they are, but remember, the sicker they are, the less likely they are to get benefits in terms of being delisted, et cetera. So in our program, if you have a low MEL score, you're Charles-Pugh A and you have cancer, we treat all of those patients at the moment. If you're Charles-Pugh B and you have not very severe portal hypertensive complications, we treat those as well, and typically use a MEL score around 20 to make that determination. But then everybody else, we basically tell the patient we're going to focus on getting it transplanted and work really hard to keep them alive to get to transplant, try to find options to do so. We feel that their benefits in terms of being treated are probably very low and that they would be better served by transplant as long as we can get them to survive to transplant. So challenge number 3, as I've just tried to outline, is this to treat or not to treat. I think it's without doubt the most challenging area. For patients with decompensated cirrhosis who don't have transplant as an option, then it's a no-brainer, just treat them. But if you have transplant in the picture, then you have to be a little bit more thoughtful and have to weigh a lot of things into that very, very complex decision about whether you should treat them before or just wait and get them transplanted and treat them later. I will say that MELD purgatory is a term that's talked a lot about, both in the literature and in transplant circles. And actually, we don't know how many people are in MELD purgatory. We talk about it a lot. We talk a lot about, we're going to have patients that are going to end up there, but we haven't actually quantified that problem yet. So hopefully that data will be forthcoming soon. All right, so the next topic I'd like to focus on is really the other end of the spectrum, is the patient who you have treated, they have SVR, and now to look at really the ability to reverse cirrhosis. I think now for the first time, when we can treat so many more patients and get cure in so many patients with cirrhosis, the idea is, can we now really have patients who will no longer be cirrhotic at some point in time in the future? And more importantly, can we remove the cancer risk from somebody who's had cirrhosis? So if you have cirrhosis at the moment, your risk, and you're not treated, your risk of cancer is 3 to 5% cumulatively per year. And what we'd like to know is, can we treat people and ultimately would they be at no cancer risk? And I think that's still an interesting but as yet unknown question. And how often do we actually get reversal of fibrosis? And I think here, both the quality and the quantity of the fibrosis at the time of them achieving their SVR are relevant. But as I'm going to show you, I think there's other factors that are coming into play and helping to us to understand what is the likelihood of getting reversal. So just a point or two about fibrosis just in general. And this is based on a very nice review on this topic, just looking at basically across all kinds of diseases, kind of this ability to get reversal of fibrosis. We know it can happen. We can make somebody who's cirrhotic, you can get somebody to be non-cirrhotic. We know that longer duration fibrosis is associated with the accumulation of these very high density fibrillar collagens. And these fibrillar collagens are much more difficult to actually, especially after cross-linking occurs, more resistance to degradation. So the idea is if you have somebody who's got, say, bad portal hypertension, they probably have a lot of cross-linked collagen, and maybe that individual is going to be less able to reverse their cirrhosis. And there's now sort of novel markers that are being used in the serum to try to identify patients to see what stage they may be at with their cirrhosis, that we can better predict somebody's ability to be reversed. There have been paired biopsy studies done where they take patients with cirrhosis, Child-Pugh A, treated them. This was with the interferon-based therapy. They got SVR, and then 5 years later, 61 months later, about on average, they did another biopsy and compared the amount of fibrosis using a morphometric analysis. And the short answer is, you can see that there's a decrease in the fibrosis in the biopsies. That overall, the area of fibrosis decreased by 89%. But it doesn't do so in every patient. So there's a small percentage of patients in which it actually increased, and a very, very small percent in which it remained unchanged. But this is, biopsies aren't perfect. No, none of our tests are, in fact. But if they're high quality biopsies, I think this does give us a clue that yes, indeed, you can reverse fibrosis. But look, this is a 5-year interval. And again, we don't know kind of how well established that cirrhosis was at the time the patient got treated. These days, we don't really do biopsies anymore, truthfully. We use non-invasive markers to help us assess somebody's stage of disease. So this is looking at non-invasive markers. So this is the APRI score, which is looking at the AST to platelet ratio, and FIB4, which includes also age, platelets, and AST and ALT. So they're using laboratory parameters to come up with an estimate of fibrosis. And to show you, and I don't think it's so surprising really, since AST and ALT are part of the FIB4 and APRI, it's not surprising that if you treat someone, you cure them of their Hep C, the inflammation goes down and those markers go down. And that's what's shown in the panel on the left. The other tool we have is, of course, liver stiffness, the FibroScan. So this ultrasound sort of device is used to assess for the stiffness. And again, shown here is that pre versus post treatment in patients who achieve an SVR, we get a greater decrease in their liver stiffness, suggesting, again, less fibrosis, but that also may be, in fact, related to inflammation. Regardless, there's some histological benefits, I think, going on, whether we're actually reducing just inflammation or whether we're reducing inflammation and fibrosis, I think, is difficult to tease out from the non-invasive markers that are being used now. But nonetheless, I think this tells us that there is a direction that the liver can improve in. The other aspect of showing improvement in terms of cirrhosis is to look and see, do they reverse their portal hypertension? And so this is a very nice study in which they did measurement of hepatic venous pressure gradient in patients before and then after their achievement of cure. And shown here on the top are the changes in the VHPG by baseline VHPG measurements. So clearly the patients on the far left with the VHPG of 6 to 8 had very mild portal hypertension, since 6 is the cutoff for defining portal hypertension. And then you can see, there's a gradient of patients with more severe portal hypertension. And you can see also that with treatment, the majority of the patients had a decrease in their portal hypertension. So that's a very meaningful outcome, because portal hypertension is, of course, directly linked with your risk for varices, directly linked with your risk for ascites. So seeing individuals who see a decrease in their portal hypertension with SVR does suggest we have meaningful changes in terms of cirrhosis benefits that are achieved with SVR. So we look like we have improvements in liver stiffness, we see biopsy evidence of a reversal, and we see improvement in portal hypertension. But in the end, it's all about survival, liver cancer, and liver failure. And so again, shown here are comparison of patients with and without SVR. And there's about a 75 to 80% reduction in your risk of liver-related death, decompensation, and liver cancer. But the cancer is the one in which you'll notice with the SVR curve there that it's a little bit not as flat as the others. So while we do a very, very good job when we cure someone of Hep C who has cirrhosis of preventing future decompensation and liver failure, the cancer risk has been persistent. And I'd like to focus now just on that risk of HCC after you achieve cure. So just before I get to that, this is just the sort of summary challenge for the cirrhosis after SVR. I'm just going to say that we're not very good at figuring out whether cirrhosis is actually reversed or not. And I follow patients after SVR, and many of them are now 5 years out. And when we do their measurements, they look like they've reversed. But when we've biopsied them, which I've done, they have not. They still have fibrosis. So I think we're still learning, how do we assess someone longitudinally to know whether they actually have reversed their fibrosis? I think the non-invasive measures, they decrease, but I don't think they really tell us about fibrosis, or at least doesn't give us all we need. I definitely think regression is possible. It's very likely, I think, over time, but how to best assess this is, I think we kind of need new tools to do that. So let me focus now on the HCC group. So, these are data that look at, on the left, 20 years of follow-up after individuals with advanced fibrosis had achieved SVR, and on the right is out to 6 years. The rate is kind of the same across every study. It's always 1% per year. That's kind of the number. So when I see patients after they've achieved SVR, I tell them, before you had your SVR with your cirrhosis, your risk for cancer was 3 to 5% per year. Now it's 1% per year. So that's a significant benefit for sure, but it's not zero. And the thing that's, I think, most striking about that figure on the left is that it doesn't look like it's plateauing. Okay, it doesn't look like you have a risk for the first 5 years, then it plateaus. In all of the studies, we just keep seeing the rate pretty consistently always at that level. Shown here, that was interferon data. And you could argue, well, maybe interferon and DAAs are different in terms of their ability to prevent cancer. And there's not much data on cancer prevention with DAAs, but this is probably the best data that exists. This is from the UK. They did an expanded access program in patients who had cirrhosis. And if you look at the highlighted boxes, this is just looking at individuals who had DAA therapy and compared them to an untreated sort of matched controls. So in the untreated group, you can see that at 0 to 6 months, the rate of cancer was 4.2%. That's exactly what you'd expect, sort of 3 to 5% a year. And in the treated group, you don't see that any benefit in terms of cancer reduction in that first 6 months. But when you get out to 6 to 15 months, now you start to see a decrement in the risk for HCC. So I think it is giving us some clues that we're going to see a decrement in the risk for HCC with DAA therapy, just as we've seen with interferon therapy. So now there have been, in the last 6 months, I think 6 or 7 or 8 studies that have all come out with the same theme. Patients who had SVR, they get cancer, and they're comparing who gets cancer and who doesn't, because we're trying to figure out, is there a high-risk group? And so this is a study of more than 10,000 veterans who had SVR. And so the most important thing to highlight is that every study shows that cirrhosis is your risk. But even when you adjust for cirrhosis, there are some other factors. So you'll see diabetes, I'm sorry, it's not red there, but it's highlighted bold, older age, and genotype 3, which is interesting because we know genotype 3 is a little bit special because it has this ability to be associated with steatosis. So whether that's the factor or not, we don't know. So that's one study. And I'm going to show you a few just to give you a flavor. So these are patients with SVR more likely to get HCC than patients with SVR who didn't get cancer. Here's a study from France. Same thing. They're looking at patients who got SVR, and then they look at who gets cancer and who didn't. And the same factors keep coming out. Here in this normogram that they developed, age, platelet count, which is a marker of disease severity, alcohol use, GGT, and of course whether you got an SVR. But age was quite important. And they came up with a nomogram where you could sort of estimate the risk as low, medium, or high based on how many points you got. And then just to give you one more, this one's from Asia. So we've kind of got studies from around the world, US, Europe, and Asia. And in their risk stratification for HCC after SVR, they identified, again, age, platelet count, fibrosis stage, and in this case, AFP. What's interesting is if you look at the patients who are being cured now compared to the ones who are cured in the interferon era, they're actually different. Not surprisingly, they're older and they're more likely to have cirrhosis. So when you look at a study which compares DAA-treated patients, you have to recognize they're different patients than the ones that we treated back 10 years ago, 20 years ago. They're older, more likely to have cirrhosis, and as a consequence, that's going to put them already in a higher risk group. But I think there's some emerging themes. So when you see a patient who has cirrhosis, you've cured them, they're really pleased, and you're talking about your risk for HCC and the importance of them continuing to do their surveillance for HCC, you want to be mindful that the older patient, perhaps the patient who had genotype 3, certainly those with cirrhosis or those that have a low platelet count, and really importantly, I think, because they're modifiable, patients who have diabetes or alcohol use, because it's probably a cofactor for really liver injury, with diabetes probably being the one that I think has is new to the scene. So what are the implications for this in terms of your clinical practice? Well, you're going to now be able to quote a number, I think, pretty soundly for your patients. 1% per year is their risk for HCC. It's pretty clear they're going to have to stay on surveillance. I tell them forever. We have 20-year data that says that the risk doesn't go down. So it's surveillance forever. So even though they got cure, and that's a really great thing, and they're probably not going to die of decompensation, they certainly could die of liver cancer still. So they need to get surveillance every 6 months for life. The highest risk group, I think, are your older patients who have cirrhosis and some element of portal hypertension. And then remember that we can do something to try to modify that risk by making sure that we're not adding to it by having fatty liver disease from metabolic causes such as diabetes or concurrent alcohol use. So my fifth and final challenge in terms of the cirrhotic group is really the management of HCC after SVR. So I've emphasized that the surveillance is for life. I think that that's a challenge for two big reasons. One, I'm not sure how much it happens in Florida, but in California, more and more of the care of Hep C and the treatment of Hep C is going to non-specialists. And that's great. We're really pleased about that. But I worry that there isn't always a careful consideration of what the stage of disease is before they do treatment. And sometimes cirrhosis can be present, and really, unless you look for it, you're not going to find it. So what would happen then is we may have patients who have unrecognized advanced fibrosis at the time of their cure who will be discharged from surveillance, will not get the surveillance they need. So I have a concern about that, and I think there's a need to get the word out that HCC is important after SVR and that you got to know if the patient has cirrhosis, one way or the other. And then, of course, we worry that patients who get SVR feel fabulous, right? They're so happy they got SVR, and they're so thrilled, actually, that their sort of life has been changed by cure, that adherence to surveillance may also be potentially important. And then finally, fatty liver disease is everywhere, and fatty liver disease is going to be a problem here too, right? So if they have fatty liver disease or alcohol use, that's going to be an important cofactor for us to try to manage. So my final slide is really just to reiterate that HCV is really an amazing time. And even for patients with cirrhosis, this is really something spectacular in terms of what we can offer them. We have transformed already the natural history of cirrhosis in these patients. We still have a small subset that are in need of new drugs. I've tried to emphasize the very complex decision-making that goes into treating somebody who's on the waiting list. So that decision usually should be made in context of the transplant physician. The importance of advanced fibrosis and the ongoing need for HCC screening, and then, of course, the importance of the comorbidities for us to manage in our care of patients. And with that, I'll stop. Thanks very much.
Norah, that was a real tour de force. Thank you very much. Before we get to the questions, I do want to acknowledge the fact that this is the 23rd Leon Schiff lecture. I don't know if Jean was here for all 23 of them, but
I've been here 48 years.
no.
Yes.
And we hope you'll be here for another 4 years. So, sitting in that seat, and we'll move it. We have to. No, but Jean, thank you very much for continuing to sponsor these lectures. And clearly, the Schiff name and liver disease is something that the University of Miami is very proud of, and we're grateful that you're here and brought Norah to speak to us today. So, Norah, the question I have for you to begin with is. The population that we see here in Miami is usually hepatitis C patients that are co-infected with HIV. And I worry because, as you say, non-hepatologists are taking care of these patients and may not be aware of some of the natural history and the findings that need to be followed up in terms of HCC and others. Is there any other special considerations that you give for the co-infected patients, other than, of course, treating their underlying HIV, that you think we need to be aware of?
Well, we talk about that cancer rate, of 3 to 5% before and 1% after. We don't actually have very good data about the after for the co-infected patients, although we think it's probably a little, it's still a little bit higher because their pre-cure rate of cancer is a bit higher as well, right? So I'd be particularly worried about them. I think also they are at greater risk sometimes related to their HIV medications for metabolic fatty liver disease, related to their drugs. So I think they have yet another cofactor. They offer co-infected with B as well as C. So, they've got the sort of multiple risks that I think could accelerate their path. So I think really the message I think we as hepatologists and really those that do treatment need to get out is that you need to know the stage. And FibroScan is a pretty widely available and easy test, and one that needs to be obtained, but it has to be obtained before you do treatment. To do it afterwards, they all look better, and it doesn't help you in making that decision. So, getting that message out and really insisting that individuals have that important, staging data done is important. And if you can't, then when you get them afterwards, you just got to start from scratch and use your clinical judgment and look at their lab results. And there may be still some role for liver biopsy here, I think, in the future.
Looking at antifibrotics in conjunction so that when the patient, to my mind, at least what I'm hearing, and obviously this isn't my field, but hang out a little bit with Jean, is that the achievement of SVR is great. But if the liver is continuing, and in pulmonary we look to the liver because it regenerates and it fixes itself, and it's such a model for us.
Right.
But what you're telling me is they're left with a disease that is ongoing, where, like what we suffer from, you don't have a peripheral biomarker or a urine marker or something that can help you say what's actually happening to the liver after it's achieved SVR.
Right.
So what about antifibrotics?
So they're being studied. So you're right on the spot. So there is interest in it. They're not doing it concurrent with or even like quickly sequential, but there are trials now available for patients who achieved SVR who have cirrhosis or advanced fibrosis. So that is actually I think it's like the perfect setting, honestly. I think it's the right thing to do is to study that next, because we have this huge pool of people that we potentially, hopefully, could pull them back even further from fibrosis. And I should clarify that I don't think we have enough studies about really repeat biopsies and kind of documenting kind of this regression. I think some people can regress. I really do think it's how long you've had sort of your cirrhosis for and how kind of, how thick the bands are and how much there's many elements. I'm sure there are some cirrhotic patients who can reverse, but I think the patients who have cirrhosis plus portal hypertension, that's probably a tall order. But that's where antifibrotics would be really interesting, I think, to study.
Last question, Dr. Fornoni.
Thanks for your wonderful talk. I'm proud to say I'm not much about it, but I do foresee that with the AA treatment, there's a lot of immunodeficiency symptoms coming. You have not mentioned the incidence of lupus-like illness that we're going to see or foresee coming with treatment. Can you comment on that?
Repeat the question.
Sure. So the question is really, when you eradicate HCV, there's reports of individuals getting kind of immunological, you can call it immune reactivation, some immunological phenomena in the setting of clearing their virus. it's probably best kind of first characterized really in the transplant setting, where we had patients who had chronic HCV, we would cure them and they would get rejection, you know, in the setting. And this was without interferon, this was just DAAs. And now there have been some reports of individuals getting sort of other immunological phenomena post-cure. I think we need a lot more data. You know, there's this concept out there that if you have a chronic inflammatory activity, that sort of your immune system sort of is kind of adjusted to that, and then you take it away, then there may be some shifts that could lead to the reactivation or immune reconstitution. But I think it's kind of early days, to be honest, so I don't know. I certainly wouldn't let that hold me back from treating anyone, you know.
Thank you, Dr. Terrault.
Thank you.
You from Canada?
Yeah, originally, yes.
Where?
I grew up in Edmonton.
Oh.